Hello, everyone. My name is Quintin Solano, and I am a third-year medical student at the University of Michigan Medical School. I would like to thank the wonderful team that I get to work with and SAGES for allowing us to present our work on ventral and incisional hernia repairs in kidney transplant recipients. I'm hitting it. There we go. These are our disclosures. Survivorship following kidney transplantation has substantially improved over the past several decades. As survivorship continues to improve, it stands to reason that intervening on common surgical diseases, such as hernia repair, will be more common as well. Ventral and incisional hernia repairs are a morbid disease associated with chronic pain, poor quality of life, and potential life-threatening complications. The transplant population is at particular risk for surgical complications following hernia repair, given their commonly associated comorbidities. The incidence and timing to incisional hernia repair after kidney transplantation and the associated clinical outcomes is not well understood. Previous studies report large variation in incisional hernia repair rates. However, some of these studies lack long-term follow-up and are limited to single centers. Therefore, the generalizability of these studies has been limited. As the number of transplant recipients increases and survivorship continues to improve, it is important that we examine ventral and incisional hernia repairs in this vulnerable population to improve both patient counseling and surgical decision-making. Within this context, we sought to answer the question, what is the incidence of ventral and incisional hernia repair after kidney transplantation, and what are the associated long-term outcomes? To answer this question, we used 100% fee-for-service inpatient Medicare claims to identify adult patients undergoing kidney transplantation from 2007 to 2018. Patients were identified using appropriate CPT and ICD-9 and 10 codes, and patients were excluded if they had a concurrent pancreas transplant or were undergoing a non-elective procedure. The primary outcomes of this study was incidence of ventral or incisional hernia repair, and the secondary outcomes included complications, inpatient ED use, and all-cause hospitalizations. Covariates included in the analysis were age, sex, white versus non-white race, 29 Elixhauser comorbidities, and chronic kidney disease stage. In our analysis, we used Cox proportional hazard models to calculate the adjusted cumulative incidence of ventral or incisional hernia repair. This model was adjusted for age, sex, year of transplant, and comorbidities. Close to 140,000 patients were identified to have undergone kidney transplant from 2007 to 2018. They had a mean age of 52 years, 61% were male, 52% were white, and had a median follow-up time of about 5.5 years. In that period, 2,098 patients underwent ventral or incisional hernia repair during that time. They had a mean age of 55 years, 57% were male, and 63% were white. Median time to ventral hernia or incisional hernia repair was 1.2 years. On multivariable logistic regression, factors associated with increased odds of undergoing a ventral or incisional hernia repair were increased age, being white, chronic obstructive pulmonary disease, obesity, and pulmonary circulation disease. Factors associated with decreased odds of having a ventral or incisional hernia repair were being male, deficiency anemias, and diabetes with chronic complications. This graph represents the risk-adjusted cumulative incidence of ventral or incisional hernia repair over time in months. The risk-adjusted cumulative incidence of hernia repair at 3 years was about 1%, at 5 years was 1.25%, and at 10 years was 1.7%. These graphs represent complications, ED visits, and readmissions across 12 years. The red line indicates patients that underwent ventral or incisional hernia repair. Compared to patients who did not undergo a ventral or incisional hernia repair, patients who underwent repair had a higher cumulative incidence of complications, ED visits, and hospital readmissions. We then thought to evaluate if ventral or incisional hernia repair rates varied across hospitals. To start answering this question, we first looked at 1-year risk and reliability adjusted ventral or incisional hernia repair rates across hospitals. We split these hospitals into tertile based on these rates. And you can see in tertile 1, the mean rate of ventral or incisional hernia repair within 1 year was 0.49. intertile 2 was 0.63, and intertile 3 was 0.98. Those are the ranges underneath the numbers. A nearly tenfold difference is noticed between, or is observed between the lowest tertile hospital and the highest tertile hospital. In this study, we found that ventral incisional hernia repair incidence is low. This could be owed to a more conservative approach in these patients, as the incidence of ventral incisional hernia development has been cited to be as high as 18% in some series. Ventral or incisional hernia repair appeared to happen fairly early on, with a median time to repair of 1.2 years. And this could be owed to technical factors of the operation or location of the hernia itself, which is often located in the iliac fossa. Additionally, we observe variation of ventral and incisional hernia repair rates at the hospital level. This may indicate that transplant program level factors such as BMI thresholds and surgeon level factors could potentially be drivers of these differences. A follow-up qualitative study is underway to help answer this question. This study should be interpreted with its limitations in mind. First, this was an observational study and is therefore subject to selection bias and cannot demonstrate causality. The true incidence of ventral or incisional hernia development could not be estimated from this data, as we only report ventral or incisional hernia repair operations. We utilize CPT codes to identify these hernia operations, and the ventral and incisional hernia CPT code combines the two. Therefore, we cannot delineate between pure incisional hernias and ventral hernia repairs. Finally, we could not assess transplant program level factors either, which could be drivers for the observed differences between the hospitals. In conclusion, the incidence of repair in the kidney transplant recipients is uncommon. Time to ventral hernia or incisional repair was early. Patients that received a repair had increased complications and hospital utilization compared to the non-repaired cohort. And future work will examine transplant program and surgeon level factors associated with the variation in ventral and incisional hernia repair rates between hospitals. Thank you very much for your time and attention. I'll take any questions. That's a great question, and that is not a level of detail that we were able to collect within the data. Yeah. Yeah, that's a really good question, and one that we discussed at length. So the rate of repair is pretty low, and the incidence in multiple series that have come out since, between 2000 and now have reported rates between 1 and 18% of hernia development, and their repair rates have been as high as 50% in those series. So seeing this rate being so low, and the rates being low just in general compared to the general population, indicates it's likely related to the location of the transplant. It's in the, in the iliac fossa, so not in the traditional midline area, so the forces of the abdominal wall could be distributed differently in that space as well. Yep. Yeah, a majority of them. There are ways to do kidney transplantations without having to go into the iliac fossa. You can do midline kidney transplants. I've read on them being described in the literature, but at least at our institution, what I'm most familiar with is them being done in the iliac fossa. Yes, so looking at, so the cohort of patients that we have in this study specifically were kidney transplant recipients, and it's very well known and described that minority populations receive transplants at a lower rate than white individuals. So I know there is work being done in our transplant department specifically that is looking at ways to remedy this disparity. But yeah, thank you. Great. Thank you very much.